Okay, welcome, welcome, one and all, to yet another episode of WIC TV. It's a cross-ideological space where we come together to talk about issues both political and cultural, from the silly to the serious. And today, we're going to be talking about trans affirmative healthcare. Is trans affirmative healthcare life-saving? Is it medically necessary? What does trans affirmative healthcare even mean? How has it been handled? We're going to go through it. We're going to talk about it. And we got a great debate today with some great people. I like every single person on here. I don't know you, Aaron, but Tali likes you, so I like you too. And we'll just get into it. I'm going to give first the mic to Soy Pill, and then we're just going to go around the room. Soy Pill, start us off. Give us what you got.
Yeah. Basically, my position is trans people exist. I live in San Francisco. I keep tripping over them every time I go on a walk. And the data that I've looked through, studies and otherwise, surveys, quality of life stuff, seems to show that gender affirming care is a positive treatment that has a good effect on suicidality, gender dysphoria, and just overall mental well being. It's interesting because I think a lot of people don't talk about this spectrum of gender affirming care in this conversation. Everyone just kind of thinks, oh, you get a bottom surgery or not, where it seems to be a spectrum of anywhere from surgery all the way back to, hey, I just want to change my name and present a little differently. And both of these things fall under that umbrella. And both of these things seem to have positive outcomes. So I've looked at the people that kind of oppose this, and upon scrutiny, it seems like the data is misrepresented or neutral at best. So just given the evidence that I've been able to analyze, and also, although I don't want to use this as very strong evidence, my anecdotal experience living in the trans mecca of America, it seems like gender affirming care works and it helps the people that are asking for it. So I support it as a life-saving measure that reduces suicidality, and people should have access to it.
Okay, well, thank you for being here. I'm sure we'll get into it as we go. Aaron, tell people who you are, what you do, and what are your thoughts. Go ahead.
Awesome, thank you. So my name's Aaron. I co-host a podcast with Tali Bots here called The Navel Gaze. I am myself a transgender man. I transitioned in 2011 or 12. I can never remember which one. But anyway, a little over a decade ago. And all in all, fits exactly what Soy here was saying. Improved my quality of life. I was very happy with having the ability to transition, and did what it said on the tin, and I just proceeded with my life quite happily for the next 5 or 6 years, until around 2017 when I encountered a number of fellow FTMs, females who were either trans-identified or male-identified, living as men or trans men, etc. Many of whom expressed that their transition was motivated by a desire to be trans, not to be male. They didn't actually experience gender dysphoria. They just felt that basically there was some sort of social good. These aren't the words that they were using, but it was clear that from what they were trying to express, that they had essentially joined a social movement, and transition was what you do to validate your involvement in this social movement. And they were quite kind of alarmed by me stating that I actually wanted to be a man, and I thought that I should be a man. Was like, the typical experience of gender dysphoria. They were kind of like freaked out by it, and it was like, oh, that's just kind of what you tell cis people in order to gain access to this, to trans healthcare. Anyway, so learning, these are people that I encountered in my real day-to-day life, and so I went back online into the kind of trans sphere and realized that the things that they were saying had become quite commonplace. So yeah, a lot of young people. These are people between the ages of 21 and 25 that I was encountering, who were transitioning to be trans, and that was again quite alarming. So I just started to re-immerse myself in the forums. Started just kind of like trying to figure out what it was that had gone wrong, like what is happening here. That's when I encountered Lisa Littman's work on rapid onset gender dysphoria, and it was describing exactly what I was seeing in these young women and or young trans men. And so I was quite relieved. I was like, okay, sweet. The professionals are aware of this and are looking into it. Anyway, so then I got immersed into the more gender critical sphere, and anyway, just started talking about the experience of being trans in the light of nothing isn't, or it isn't all what it seems behind the scenes, essentially.
Okay, well, I'm sure we're gonna get into it as we go. Thank you for being here. Right, I didn't mean to cut you off there, but like, we're already late,
Yep,
right?
sorry.
We gotta get through. We gotta get through.
Yeah,
These are
good.
just opening thoughts. Erudite, welcome to the show. What are your thoughts? Trans affirming healthcare, yay or nay?
Hello. Yes, thanks for having me. Yeah, I think the trans affirming healthcare is a complicated question, and I think I'm excited for the conversation because I saw Tally speak before. I think she's extremely capable, so I'm excited. But it seems like the opposition is also really, really informed. So I suspect that this is probably going to be a lot less blood sportsy. Um, One of the things that I keep hearing is these elements of the nuance within the community that is probably being underserved both at research and in communication, right? I think what Aaron, am I using your name correctly, Aaron? I think what Aaron brought up about the rapid onset individuals versus there's also a cohort that typically seems to notice their dysphoria at puberty, but not before, versus individuals who at about 2 to 3, like basically as soon as they can verbalize dysphoria, are verbalizing the dysphoria. And there's kind of these 3 categories of individuals that we see, maybe potentially more, and they kind of all get broad brushed as the same treatment modality. But also, as Soipo pointed out, gender affirming care is spectrumal as well, which is good because if it's a spectrumal disorder, it should probably be spectrumal in its care. And so I am pro gender affirming care. I think that trans identity is neuropsychological, but also neurobiological. However, there are ways in which neurobiology is plastic, and it's important to kind of understand all of these elements. I do think that gender affirming care seems to overall lead to a better outcome for the trans individuals that undergo the procedures and the treatments. It leads to higher quality, less dysphoria, higher quality life, less dysphoria, less time off work, et cetera, et cetera. All the markers that we look for functioning and flourishing. So I am pro GAC, gender affirming care.
Hey, thanks for being here. Really appreciate you coming. Last but certainly not least, the person responsible for this panel, because she asked me to set it up, Tolly, what you got?
Okay, I will try to be concise, but as I told our opponents last night in our group chat, this is a topic that I care a lot about, and I'm really excited to be speaking with the two of them because I think they're thoughtful and smart, and I'm hoping that I'll actually be able to change their minds in some way. I think we're starting with the same outcome in mind, which is for people with dysphoria and trans people to have happy, well-adjusted, successful lives and to have access to medical care that is helpful for them and that they can understand. The reason that I'm against gender affirming care, number one, is because ultimately they don't actually know what they're treating. And so I'm not against hormone access. I'm not against surgical interventions for trans people. I am against the system that functions on very low to moderate evidence at all and kind of tells people or sets people up with expectations that are not always realistic and that are not always informed about what the actual long-term outcomes are. I know we're not focusing exclusively on children here, but gender affirming care in the standards of care from WPATH, the World Professional Association for Transgender Health, does include youth gender affirming care, and there are even more concerns that I have about that and our ability to actually determine who is going to benefit from this care long term. So not only do we have the issue of people who detransition, who might have regret for the interventions that they had, we also have people who go on to continue to identify as trans for the rest of their lives, who have regret about some of the interventions that they had. Gender affirming care in some cases can actually limit the potential for different surgical outcomes in the future, which was something that it was attempting to control for, especially when we're talking about early intervention and youth intervention. And so ultimately what I want is for trans people to have the most informed care possible, and I don't think that the infrastructure that we have today is doing that. I don't think it's a conspiracy. I think most clinicians and doctors who work with this population believe they are doing what's best. But I think there's been unfortunately a real capture of the of the academic research amongst activists, and that is to the detriment of those individuals and the trans community at large.
Okay, well, thank you for being here, and we will get into it as we go. Well, that's the floor. That's the setup. I guess first question, right, that we have to ask, um, gender affirming care. A lot of people have said and claimed that it's being pushed, and Tali just mentioned it's being pushed by activists, right? That a lot of people are being pushed to be trans who would otherwise not be trans, and they go through procedures, take hormones, and do other things that they come later to regret. Um, do we agree with this? Do we disagree with this? I want to hear from Soy Pill and Erudite first.
So is the question that there are people who may otherwise have not self-identified with some sort of gender dysphoria, but because of the community at large kind of making this a positive movement, people would otherwise fall into that camp, kind of what Aaron was describing. Is that the question?
Yes.
I don't think there's a huge amount of that. I think if you look at the CAS report, they kind of indicate that the exponential growth of people identifying as trans is kind of more than what would be expected, although there are refutations of this, and I'm not quite sure to what extent that is happening. Although I can for sure, like anecdotally say that, like I said, living in an incredibly progressive area, I do know people who have verbatim told me I was bored of being cis and not having anything to do with transition as a gender dysphoric thing, but rather, I wanted to be trans or I wanted to be different. I'm sure this does happen. To what extent that's harmful, though, is a completely different question because these people, again, are not incredibly, in pain or unhappy. They seem to be happy from my knowledge. And I guess the question is, and maybe this is something Tali agrees with, if these people are seeking some sort of gender affirming care based on both the WPATH and the Endocrine Society and even the CAS report, they kind of recommend a holistic, multi-stepped, multifaceted approach from doctors and psychologists to make sure that you do indeed want something that is a very serious, potentially irreversible thing like a surgery. If that's indeed the case, then if some of these people are socially contagioned, so long as they meet the criteria, I think it's fine. And they think that the people that wouldn't be suffering from gender dysphoria wouldn't meet those criteria and therefore wouldn't be harmed because they're not getting some sort of irreversible change to their bodies.
I jump in before
Yeah,
Erudite
open
goes? Okay.
discussion. Go ahead. Yeah.
Okay. So I partially agree with you, and I even want to take some of the loading off of like terms like social contagion and like like the groups like Gays Against Groomers, for example. As a gay person, I don't associate with any of that messaging. I don't think that trans people are out there trying to recruit cis people to turn into trans people. I don't think any of that is happening. I think rapid onset gender dysphoria and the social contagion that people like Abigail Schreier have written about is much less nefarious. It's much more kind of like, especially when we're talking about the young females, it's women having very like emoting very relationally, feeling and taking on very strongly what their friends are taking on. It's also potentially an example of like the symptom pool where people are actually experiencing distress. So these kids are actually extremely anxious, extremely depressed, might have issues with their own body. And when they look up like what does this mean, trans is the answer that's given to them. So I don't think that this is like some conspiratorial push to make the frogs gay or make the kids trans at
Yeah,
all.
I wasn't accusing you of that, but
Um,
I'm saying that it is like
sure.
a movement that some people feel not pressured into or like even groomed into is such a silly word, but people that like might adhere to something that turns out not to be gender dysphoria, which is why sometimes you see when you poll people who detransition, some of them say it's because of not enough acceptance. I think that's the majority. Over 50% say it's because my community didn't accept me, but some of them say like, hey, I thought I was, and then it turned out it wasn't that, and that's totally fine. Especially when it is like, hey, I got on puberty blockers and I went off, or I took testosterone for 6 months and realized, you know what, I don't think I have gender dysphoria. That seems fine.
So
I
the
mean,
reason, oh
Oh,
sorry,
go ahead,
just
Erudite.
the
Oh,
okay, yeah.
Erudite first, then we'll go to Tali, please.
I was just going to kind of like bridge. I think social contagion, particularly from social media, is something that's kind of going to be understudied for a while. This reminds me, this is very akin to the Tourette's conversation that emerged during COVID, where a lot of like 13 to 15-year-old girls were showing Tourette's symptomology. But it was around the same time that Tourette's TikTok was really popular. People just really enjoyed like watching cute Tourette's teens making cookies and spilling things all over the place and just doing little silly little antics, right? Um, and there was this interesting phenomena where we did see an increase in Tourette's presentation. The issue is that most of it just resolved pretty quickly when you like removed access, or if you just like kind of like countered them on it and being like, do you have Tourette's really? Like the moment that like some of the self analysis was applied, you saw a massive diminishment of those symptomologies. The interesting thing though was that that wasn't the case for all of them. And so there's this interesting question of, okay, well, to what degree is the people that were lumped into the study as the contagion group, to what degree were they always going to develop Tourette's? To what degree is Tourette's epigenetic enough that social media can be an environmental trigger that triggers these type of genetics? And I think that there can be this akin question to transgenderism, because I do think fundamentally transgenderism is a neurobiological phenomena. I think there is evidence for it occurring within the brain and at the brain level. But if that's the case, in the same way with like even something like schizophrenia, if it is the case that it is neurobiological, there are neural correlates for it. This does mean that environmental stimuli can potentially trigger it in the way that certain weed consumption, if you have a genetic marker for it, can trigger schizophrenia and it will be permanent. And I think that that's a really interesting conversation to have. The issue is that it's a very, very, very teeny tiny amount of the population compared to, I think, what typically we talk about when we're talking about contagion behavior.
Tali, you had something to say, and then I have another question to maybe move this a little
Yeah.
more contentious.
So I think I want to pick up on the neural correlates thing, but I'm going to put that to the side for now and just get back to something that Soypil was saying. So, when we're looking at things like the Cass report and then also looking at gender affirming care in the United States, frankly, unfortunately, we don't really have the same systems. And the UK, where the Cass report was, where they needed to initiate the Cass report and take a look at what they were doing, because the outcomes that they were having were not what they had expected. They found that it was severely lacking there, where it's much stricter than it actually is in the United States. So because we don't have we don't have the NHS, we don't have one central healthcare authority, we don't actually have ways of tracking these things or making sure we're not holding any clinicians to account for whether or not they are holding to the standards of care from WPATH. WPATH has its own issues. So the problem is, and it sounds like I'm not giving any opportunity for a win here, but not only is there no consistency in the United States among providers of how they are implementing standards of care. The standards of care themselves are severely lacking on the evidentiary grounds. And so what is the problem if someone goes in and they later find out that it's not for them? Well, the problem can be severe depending on the sex of the person, how much intervention they had. And also just the fact that we're framing this as necessary medical care, where I think, again, I'm for trans people having access to this care. I think it's better classified as body modification, elective plastic surgery, things like this. And I feel like people should have access to them, but not under the premise that this is going to save their life or really improve their quality of life all that much, because we don't have hard evidence to prove this.
We
I want
do though,
go ahead.
right? Like one of the biggest issues, I'm not sure if you're familiar with the Yale review of the Cass study, but the Yale review is done in large part, I don't think by WPATH, but I believe that there are people that have worked under WPATH in America for a long time. And one of the issues that Cass review specifically has is the standard of evidence that it calls good evidence is well beyond the standard of evidence that we actually utilize in clinical practice, right? Because when it comes to medicine and clinical practice, we typically look for even low to moderate evidence before we begin implementing trials and whatnot to help people. Because in the case of clinical care, right, if anyone's had a doctor and they've looked at you with IBS and they're like, not really sure. There's, just so it's clear, the treatments of IBS, very weak evidence for most of it. But the doctor is going to make almost all of those recommendations and continue the process of trying to give you care, because even though there might be like weak access or weak evidence, and typically it's not that it's weak evidence. There's about medium to low evidence for gender affirming care, even for youth, but especially for adults. The evidence is really high for the massive limits that emerge in the nature of the care itself, right? RCTs are almost impossible to do with gender affirming care because, for example, none of these studies can be double blind, because if you're getting estrogen and you're a man, you're going to know if you have placebo or not because your tits aren't going to grow, or they will. And then all of a sudden you're not double blind. And if you're not double blind, you're not going to have you're going to have a crazy attrition rate, because if you're not growing the tits in 6 months and your cohort is, you're going to be like, "Oh, I'm on placebo. Fuck this shit. I'm out. I'm going to go try a different trial." Right? And so like the standard of evidence that Cass is demanding is well beyond the standard of evidence that we require for any other type of care. And we can maybe have a conversation about like how we improve quality of care for trans kids, because I'm all for that. I'm very, very for that. But I think we have to be very honest and fair and even-handed in how we evaluate trans care, and not put trans people and trans workers at a higher standard of expectation than we have for anybody else, just because it's a politicized topic.
The thing is, though, we're not putting trans people at a higher standard. We're putting the specific medical interventions at a different standard than we would. So interestingly, I have a friend, might be a strong word, but an acquaintance of mine who I get along with and talk with a lot on Twitter, who is a trans woman, who is a gastroenterologist, and she's like a highly regarded specialist in the field. And she and I have had very similar conversations about exactly what you just said, Day, right? About the low to moderate quality of evidence for a lot of IBS and IBD treatments. And that doesn't mean that we deprive people of these treatments. But again, we're talking about the intensity of the intervention, right? So we would have different standards for intervening with, something like Prozac, right? Some type of like low dose of Prozac versus open heart surgery. And those are two extreme examples, but it's not that different from what we're talking about here. Trans interventions, medical interventions, many of them are completely permanent and life altering. They are much more serious than, trying a
When
a
you say
diuretic, right,
many
for
of them,
to help with your IBS for some short-term period of time. And so I do think that, yes, we can't throw away all of the healthcare for trans people just because the evidence is low to moderate, but we absolutely do need to have different standards when we're talking about such intensive intervention.
well, can I ask you to clarify when you say that many of it is like irreversible or many of it is like permanent? Because it doesn't seem to be the case when we talk about this spectrum, right? Like, is Wick talking right now, or am I lagging out? It's like,
Hello? Discord working?
am I back? I don't know if that was me or you.
Was it me or you guys?
Oh,
Who was
I'm glad it was
dropping?
all of us.
Did
Okay, it was all of us.
Discord is betraying me? Okay, I
Wow.
think we're back.
As
Yeah.
long as it wasn't just me, I was like, I've had so many tech issues today. I'm gonna actually fucking off my
I
phone.
thought I was like, oh man, we're gonna dip. Oh no. Okay, so I try again.
Right.
You had a question.
Well,
Go
one, I
ahead.
wanted you to clarify the idea of like you said most or a lot of this is irreversible. I think like of the gender affirming care treatments that I know of to be like permanent, I think surgery is obviously the one everyone thinks of. But like even puberty blockers, hormones, like all of these things, while they might have things that don't ever go away, the idea that they are like these permanent life altering things that require like this super extra scrutiny, where we still allow lots of other like very necessary medical interventions like surgeries for knees or gastrointestinal or any of these other things, seems like a much higher degree of evidence specifically for things that don't cause long-term damage. Now if you're specifically talking about the bottom surgery or like mastectomies, I get what you're saying, but I don't think that's most of these gender affirming cares. Was it lagging again?
How is this? Is it me again, or is it you? Who's it? Who's going?
glitching.
That was me
It's
too.
just Discord.
You're being DDoSed?
God damn it.
I think I heard most of what you said.
Okay. Yeah, basically, one more time. I'll
Sure,
try.
we're just
Let's
gonna continue
see.
like this?
Well, then if it lags out, I guess. But my question is, it doesn't seem to be the case that any of this or most of this stuff, a very small fraction of it, is this permanent, completely irreversible things. And I think what everyone thinks of when they think of that is mastectomies and bottom surgeries versus testosterone, estrogen, puberty blockers, any of the other things that would fall under things that are not going to cause long-term, permanent, irreversible changes to your bodies, or if they are very minor things like potentially secondary sex characteristic enlargement, or like bigger clits, I know is a thing that happens, but it's not like this, oh, your life is over now because you made a mistake. If you're advocating for more checks and balances for people who are going to get the most irreversible thing, I would agree. And the CAS report says that, as well as the Endocrine Society and WPATH. But if you're saying these things are mostly irreversible, I guess I'm asking you to elaborate. Like, what do you mean by that?
So, Aaron, if I don't know if you want to jump in. So even I do feel like you're downplaying to a certain extent some of these things. So you're right. Not every intervention, even medical intervention, is going to be irreversible. There also are sex differences here that are notable, right? So a male who's taking estrogen and changes his mind and decides that he wants to detransition is going to have an easier time passing as his natal sex than a female who's been on testosterone for the same amount of time. And we can say, oh yeah, like your clit might grow, but this can cause like extreme discomfort, sometimes not fitting in people's underwear anymore, rubbing up against their I mean, it's like
It's
silly,
easier to
but
find.
it's easier to find, but these are these are not such simple things like, oh, it's only secondary sex characteristics. Well, that's a big deal, especially for someone who's experienced dysphoria before, who is having all of this severe distress around their secondary sex characteristics. We're in some cases, in people who regretted, who detransition, we're inducing dysphoria essentially for them, after the detransition point. And yes, I do want higher level of consideration for people who are going for those most invasive types of procedures. But actually, I even think the sort of gatekeeping solution that a lot of trans people themselves and kind of moderates in this space point towards is extremely flawed. And so I ultimately take actually more of like a radical trans activist, like the Andrea Long Chu approach, which is essentially anyone should be able to get it for basically any reason under the category of self-determination and body modification. And so I do think in order to get to that, I think Aaron and I have similar end states where we would want sort of open informed consent, maybe different ideas of how we get there, but informed consent would mean notifying people about what the common causes and pathways to gender dysphoria are, giving people information about what they can realistically expect from these types of interventions, and not associating legal accommodations with these things either, because all of these are things that can incentivize people in the wrong way, potentially to their detriment. So I think about people who are trying to make pragmatic compromises on things like trans women in sports and in bathrooms and stuff like that. And people will say like, oh, well, we can just make the standard that trans women who have had bottom surgery, should be allowed in restrooms. And it's like, well, that might influence more trans women to have bottom surgery who wouldn't necessarily want that or need that. And that's a whole complicated thing just for them to be accepted as a trans woman. And so I don't think that we should be, I think that there's dangers of going the strict gatekeeping route as well.
Can I want to get Aaron in here a little bit, and I want to ask a question to Aaron and to Tali's side, right? Because we talk about a lot of the wide variety of medical interventions and how it's being handled in America, right? So I'm not talking about Europe or Britain or anything like that, but in America, in the West, right? How is our system handling trans healthcare? In what ways do you find it failing? In what ways do you find it harmful? What are your your biggest criticisms of the current way that the medical field and society handles trans healthcare? And I want to go Aaron first, hear his opinion, and I want to get open up discussion like that. Go ahead, please.
Awesome. Yeah. I'm really glad you asked that, because like bringing up the CAS review it doesn't really make a lot of sense in the U.S. context, because as Tali already alluded to, we don't actually keep the data. We don't do the research into actually these treatments that are being provided. There aren't assessments like people think that there are assessments. The providers, like one of the major trans healthcare providers in the U.S. is Planned Parenthood, and all you have to do as an 18-year-old girl is show up and say, I'm a trans man, I want a testosterone prescription. And they say, great, you want to start at 25 milligrams, 50 milligrams, what? And then when you need to go get your, if you decide to go get a top surgery, you can I'm not exactly sure actually what the requirements are currently, but for a while it was using you needed two referrals from a mental health care professional. These mental health care professionals do not know what they're diagnosing either. They don't know what they're treating. They just know that the only solution for gender dysphoria is to give you what you want. And so they write this letter saying, I, think that so and so is qualified, or I recommend like it, or it's whatever it's a canned statement that is essentially saying I'm recommending this top surgery for this person that I've sat with for 15 minutes and I don't actually know from Adam, but because they have no other alternative. There's no alternative treatment, and it's just, this is what you do when someone says they're trans. You give them the transition treatment. And if in Oregon, I think it's like 15 years old, you can make this decision for yourself without any any guardrails, it's completely Wild West. And Erudite was referring to that there's like these neurobiological correlates. If that were true, then we could test for it. We could actually determine who is trans and who isn't. But there's
No, that's not true. That's not true for any mental health
Yeah.
condition, right? If you could medically just test for depression, we'd have it. But there are neural correlates associated with depression. We understand that depression's real and that you can find it and that it's a thing that we're testing for. But there isn't like a part of the brain, there isn't like a bundle of nuclei that I can point to and be like, there it is, like, there's the depression. I found it. But that doesn't exist. In fact, we don't even have good biomarkers for things like ADHD, which is an extremely genetic disorder, right? Or schizophrenia. We really just don't have these things, even though, like, for example, there's evidence, for example, that the putamen in at least male to female transgender people, the putamen is a part of your brain that's within the limbic system, and it is enlarged in women. And in transgender women, it is also enlarged to be closer to the volume size of women versus men, right?
So
There
that's
are
this isn't this
actually measuring sexuality, that study.
the
or
putamen study.
rather
It
it's
was looking at
it's a
transgender. It was
proxy.
looking at men.
But
It's a
hold on.
proxy.
Hold on, one at a time.
Sorry, it's a proxy. So what they're identifying as trans women's brains is what they're seeing in effeminate homosexual brains, essentially. And so it's a proxy for homosexuality. The neural correlates that we have are for homosexuality, not specifically for being a trans woman.
there's
So
gay
for
brains,
example,
is what you're telling me?
those neural correlates do not hold if the trans woman is attracted to women, which makes up something like 89% of the self-report of like the largest study of transgender adults that we have. And I don't use that as a boogeyman. I'm very pro-transbian. All my
Sure, but this
followers
isn't the only
on
neural
Twitter are
correlate.
basically that. But
This isn't the only, like,
neural
sure,
correlates they are literally for
Well,
homosexuality. They
let
don't
Erudite
hold
go.
for the
They're not.
overwhelming majority of trans people.
They're just not as well though. And the issue is that the neural correlates that might like precede sex, I've looked at the studies as well, right? When you look at changes in like the
Did it control for
Hold on,
sexual orientation?
Let Erudite
So-
go for a minute, please. Go ahead.
Yeah, so it was looking at specifically, it was, I don't know, I'll have to go through all of the specific studies. I don't have I'm looking at like 9 etiological studies right now. So in another study, there was a reversal of the INAH3 in the subnucleus of the hypothalamus, right? That we see in transgender people. Now again, this could or could not be something, right?
Homosexual trans
It
people.
wasn't-
It is. If you look it up, I understand what you're saying, and if you look it up, that is what you're going to find. So we do have neural correlates, and by the way, homosexuality is an etiology. It's a known pathway to gender dysphoria and to trans identification. So it's not surprising that we would see these neural correlates, but they don't actually hold when you control for sexual orientation.
But again, that might not even disclude anything, and I'm not going to fully grant to you. I'll look for
It
it.
excludes
right?
something like
You gotta let me
89%.
finish my speech.
trans
You gotta let
women.
me finish what I'm saying. You gotta let me
Sure.
finish what I'm saying. The issue is that if we have a consistent potential theory, we know that sexual dimorphism begins around the 3rd week of development, and we know that there are some key areas that are being developed within the limbic system, and there is some level of sexual dimorphism that we expect to emerge. There is reasonable to believe that it's possible that this is where transgenderism might be burgeoning from. And it is quite likely that the pathways in parts of our brain that are important for sexuality might be similarly aligned next to gender, in the same way that it seems like autism is somewhere within these correlates as well. But nobody would say that because autism and transgenderism might share similar neural correlates, that now both of them aren't true, right? Because if that were true, then OCD wouldn't exist either, and neither would addiction.
Well, but that's not
because
what we're
addiction
saying.
And OCD, well, it is what you're saying, right? You're being like, well,
No, because
these
I'm
neural
not saying that
correlates. Hold on,
autism.
you don't.
I think autism, gender, and sexuality, I think those things are closely linked. So it doesn't surprise me at all that we see similar patterns in neural correlates. So I'm not
What
saying that
you're
none of
doing,
these
though,
things
is you're
exist.
saying
I'm saying
none
they're
of these
not
neural.
pointing to what we think they're pointing
Okay.
to.
Okay.
What
I know
what I'm
everyone's.
saying is that they are suggestive of the things that we're pointing to, right? Because if we were going to reduce neural correlates down, then yeah, we don't really know the difference super well between things like addiction and OCD, because a lot of them happen in the same areas of the brain. But obviously, we think that OCD and addiction are different because of their phenomenological presentation. And so this isn't to say, yes, here's transgenderism in the brain. I've never said that that's the case. What I'm saying is there are neural correlate pathways that we are seeing consistently, repeating over and over, that yes, have comorbidities with other things. But it's important to look at these things and go, this is something that is reasonably legitimate. There's no reason to believe that it isn't legitimate.
One of the issues, or the I guess the criticisms of trans affirming healthcare I hear does center around homosexuality. However, um, can she still hear us? I hope so, because this is kind of addressed at her.
They took their headphones off, so possibly not.
Oh no. Okay. But okay. Hopefully she's okay. Uh, I'll just say it anyway, and when she gets back, if she can't hear us,
No, she's back.
that's fine. Oh, she's just getting a drink. Okay, she's back. Wonderful.
That's right.
We can. No, it's fine. It's fine. But this was kind of referring to what you were saying, so I wanted you to be here to hear it. So one of the criticisms I hear about trans affirming healthcare is that it is erasing homosexuality and misidentifying someone who is homosexual as trans. And would that not be important? Or if what Tali is saying is true about how 89% of these people are just homosexual,
She's
Opposite.
saying the
That's
opposite.
actually the
okay,
opposite.
opposite of what you're saying? Okay, maybe I misheard then.
But your question is still valid and is I think pertinent, and one that we should address. But it is the statistics are the opposite. And when
Okay.
I'm talking about homosexual and heterosexual, just for clarity, I'm talking based on sex, so not gender identity. So
Yeah, but I guess what guardrails are currently in place to make sure that we aren't just misidentifying someone who is just homosexual and saying, well, actually, you're trans? Do we know? What are the current guardrails in the, and I'm asking this to Erudite and to Soypill, what are the current guardrails in the system, if any?
I don't know.
I don't have WPATH memorized personally. I'm not quite sure. I suspect that there are guardrails for this, right? I imagine that there are going to be questions. For example, typically when kids are doing this, they're taught to say in gender reference clinics, they're typically taught to say that they aren't gay or anything like that, or questioning their sexuality, so that they can move on to gender affirming care, right? And so it sounds like there is some level of checking to try to affirm whether or not this is sexuality. And to be clear, I would never deny that there's going to be some level of comorbidity. You guys are shaking your head. I'm dubious that WPATH is so negligent in so many ways that they're not in any ways wanting to see off ramps, because I'm reading through Yale right now. Do you have any evidence of WPATH being so negligent that they like actively want to just see kids getting harmed?
they don't want
Yes,
they
yes.
don't want to do sure.
Hold on,
And I don't
Aaron
think they
is
want
saying
to
yes.
do
I want to
any
hear
of
what
it.
Aaron has to say real quick.
Yeah.
Aaron, you're saying yes?
Yeah, no, I don't think they want to see kids harmed, but I was literally at the WPAS conference in 2023 when they were unveiling the Standards of Care 8, and I asked them how they can determine, or how is there any way to determine the difference between a kid who's going to grow up to be cis and a kid who's going to grow up to be trans, and I was kicked out of the conference for asking it. They have no answer. I was just repeatedly
one
called
of the
transphobic for even asking.
Yeah, so here's one of the problems, and this is, I think, something that everyone here can relate to. We're living in such a polarized political environment, and so everyone kind of bunkers down on their sides. And so I don't think that there's some conspiracy again to withhold the truth or to hurt anybody here. I think that, and what we've seen actually come out in recent years, and as recently as like a couple of days ago, is there are researchers and people high up in WPATH who are nervous about any crack being used against them and being used against trans people and barring trans people from getting access to care. So they are afraid that if we show that some of the evidence here was lacking or some of the gatekeeping mechanisms here are lacking, that the Republicans are going to come and take their health care away. And by the way, that seems to be founded in some reality, right? So there's understandable reasons for them doing this, but that is what happened. And so just to address the sexuality component specifically, you are partially correct that historically, especially, trans people would go into the health center and they were actually told to say they were gay in based on their birth sex, right? That they were attracted to the same sex so that when they transitioned, they would be a straight couple, right? Because it was the purpose of this intervention was to only select the trans people who they believed could normalize into society. They didn't want to be creating more gay people. So a trans woman attracted to women would go in and lie and say, I'm attracted to men. And that would help her go through and get the treatment that she wanted, deserved, was entitled to, whatever. We don't have this problem anymore. You cannot reject someone for medical intervention, trans medical intervention based on their sexual orientation. So I don't think we have high occurrences of people lying about their sexual orientation. One thing that we have is a huge conflation because providers are not assessing, they're not at least defining their terms. So they're not even assessing whether the person in their office is answering their sexual orientation based on gender identity or based on their sex. And so a lot of, especially the younger cohort, they're going in and calling themselves gay. You'll have young females going in and calling themselves gay. What they mean by that is they are attracted to men. They are heterosexuals who see themselves as gay trans men. But those questions are not even being being asked. So
Can
we
I
have
ask Holly, because this
almost
has been going
no.
on for a while, and I've been wondering this since the beginning, which is like
Yeah.
I do not know the WPAS specific requirements when they ask these questions. However, when this idea that this is conflating some sort of homosexuality into transness, if they're looking for and trying to identify people with gender dysphoria, how much of this dysphoria is attributed to the idea that they are attracted to a certain sex, and like how is that at all going to play into the diagnosis, other than, well, I think I'm straight or I think I'm gay, therefore I must be trans because one of these things is mismatched, and not, hey, my body actually genuinely feels wrong. I feel genuine mental distress looking at the secondary sexual characteristics that don't match what's in my brain, which seems to be much more of the indicators that I have heard that is tested for, not who you're attracted to.
So, interestingly enough, I think it's kind of funny because Aaron and I push back. We don't have many fans in the gender critical space either, which is, whatever. But Aaron and I push back vociferously on this claim, like, stop transing gay kids, stop transing the gay away. We don't think that is happening in the overwhelming majority of cases. The overwhelming majority of cases, I have no concern that these are true gay boys and gay girls who are going down a path that is not right for them. There is let's say 10% of the trans population who is homosexual. I don't think that's a reason for them not to transition. Again, homosexuality has been seen as one etiology, one pathway for gender dysphoria for at least the last, well, honestly, like the last 100 years, right? Because they saw it as sort of like sexual inversion, but even seriously within the last 30 and 40 years. So it's always been acknowledged that for whatever reason, homosexuality can be a predisposition for developing this severe gender dysphoria and sex distress. And I think that the sex distress and gender dysphoria is good enough reason for someone to transition. I don't think someone should be barred from transitioning because they're homosexual or because they're heterosexual.
So-
However,
Yeah, go ahead,
Yeah.
please.
I was just going to say, it's interesting the groups that Kyla delineated a bit in the beginning. I think actually the group that we need to have the most concern about, ironically, is the group who, from the time they were 2 or 3, are projecting this gender incongruence, because that group is actually the most likely to desist. So, ironically, the group who has this sort of onset of severe gender dysphoria, not necessarily rapid, but let's say adolescent onset of gender dysphoria. It's slow progression, not influenced by their friends. They grow up in a religious commune or something like this, right? Those that tends to be persistent across their lifetime. So it's actually the very young, sort of effeminate or super tomboy kids who the desistance literature tells us are more likely to be the ones to grow up and desist and to come to terms with their birth sex and identify as a homosexual when they are an
How much
adult.
of that is because the literature that would be looking, so for example, most of the literature that looks at desistance is older literature because the reality is that the
Yeah.
clinical options for desistance aren't offered anymore, right? There isn't really a pushback on gender anymore. But one of my issues with the literature as well is that you're looking at a group of kids that are probably the most severe potentially in their gender dysphoria because they're presenting so early. And so the data showing that they desist the most is there's a lot of issues with the desistance data that I won't even necessarily get into here that we're citing from about the 70s to 90s. But on top of that, this group is being viewed as the most likely to desist because that's probably the only group that even got studied in the 70s, 80s, and 90s. Because if you're 12 and 15 and starting to feel this, you're probably massively shunted away and probably not often included. I don't think people were even thinking of these people by the time they're 15. They just thought they were a weird 15-year-old who then becomes a weird adult, and nobody cares that much about weird adults, right? That's my suspicion. And so even saying that like the 2 to 3 are the most likely to desist, I'm extremely skeptical of because all the early data on this population is oftentimes biased in the pressure to not see this population exist and emerge. And there is a high level of conversion type therapy, which does not have good outcomes for gay kids or for trans kids. Even though they might desist, the quality of life that they lead afterward is not typically very high, right? And same with gay kids who desist being gay from conversion therapy as well. And so one of the issues is that one of the issues that we're all going to be running into here is going to be the paucity of literature on this population, right? For example, the things that you're pointing out of the studies that show the neurocorrelate differentiation. You're right. Most of the studies that look back, they don't have the control for homosexuality. The issue is that that doesn't mean that the evidence of the neurocorrelates now doesn't exist. It means that you need further studies with further levels of grouping done,
Sure.
which
Yeah.
good luck doing. We can barely get research for just longitudinal studies on these things because everyone doesn't want to do it. But on top of that, just because there is transness and homosexuality being comorbid, it doesn't mean that both of these constructs aren't real, which is why I agree this data has to separate them. But that also isn't evidence because I think a lot of people would take away from your statements that if it's not controlling for homosexuality, then the neurocorrelates that we're finding is just gay kids. And I was like, that's probably not true.
Well, but and again, I want to reiterate, gay people can be trans too. Hashtag free the gays. So I don't think
Sure,
that
but that's not
when I
really a
think
response to what I'm saying, right? I've never even implied that gay kids can't also be trans. What we're talking about is the separation of kids who think they are trans and they end up just being gay. And it's really important to understand that these neural correlates can overlap and both of these groups can be true and that third group can be true. That's what I'm trying to argue.
Sure, yeah, and I'm not disputing any of that. What I'm saying is, especially when we're talking about youth intervention, and again, my understanding, Kyla, is that you have reservations about youth intervention. And so my concern is this is the group who's going to be having the earliest intervention because they have the earliest onset, when this is really the only group, like you point out, that we really have any information about desistance on. And it shows that let's even use the lowest estimate, right? Something like maybe 50 to 60% of them might grow up and be able to assimilate into their sex.
Can
So
you
I
guys
think we need to
answer?
be very
Yeah, just can you guys answer a question for me that I have, real quick? You keep mentioning, youth care, right? And especially with these interventions on this cohort of people who are 2 to 3 when they express these signs of dysphoria. What commonly happens? Walk me through the steps. 2 or 3-year-old, someone starts talking about how they may have dysphoria. This gets brought up and brought toward the attention of a medical professional. What is the path that is currently, uh, what happens to them?
Yeah, correct me if I'm wrong, especially Aaron, if you're trans. You probably know better than me. But my understanding is that up until like even pre-pubescent children, it's almost all social transition. So that might be trying to express your gender a different way, maybe going by a different name, pronouns, but almost no medical or physical like interactions are happening at that point. And then once you get to prepubescent, that's when they start recommending potentially puberty blockers, then or hormones, and then past through puberty and past puberty is when maybe they'll suggest mastectomies, maybe some surgeries if that is recommended. But it's a whole spectrum, and that's why at the beginning we tried to talk about this umbrella of gender affirming care. Not everyone needs a surgery or thinks they need a surgery. Not everyone, even some people like only want to be socially transitioned and they just shave their arms and like grow their hair out. And so it's not this like all encompassing like yes or no. It is when and where and to what degree do they need what they need.
Yeah, I would agree with that.
Okay. Well, what does anyone have a problem with that? If we are not okay, as some people have expressed reservations with youth trans care, what's wrong with that? With what you just expressed?
The social transition is actually pretty monumental when you're talking about a child's development. It can really kind of cement the opposite sex identity that could have otherwise just sort of been kids have phases. This
So to be
this could
clear, Aaron,
entirely
you're
be.
against it, is what I'm hearing.
I'm against. Yes, I'm
Okay.
against social
Yeah.
transition for children. Yeah, yeah.
Okay, keep going. I didn't mean to interrupt. I just wanted to clarify.
Oh no, yeah. But yeah, for that reason, because it cements this opposite sex identity that could otherwise have been potentially outgrown, and then it's when they start approaching puberty that that physical dysphoria is going to set in where they could have otherwise avoided it, right? If they didn't have internalized this sense of supposed to be the opposite sex, everyone around them is using opposite sex pronouns, like they have this entire opposite sex understanding of themselves, and then puberty just becomes this really existential threat of where your body is going to change in all these ways that are completely contradictory to this identity that has been formed around you by adults. And it's just really, I think, not just for their own sense of identity, it's very, I think, destabilizing about like just kind of like biology, like material reality in general. If boys can be girls and girls can be boys, and there's just I just think on a much greater level than just personal identity, it seems quite dangerous to instill this idea in children. But then yeah, once you get into the fact of like puberty blockers and really kind of stunting maturation and development, it's just there's a lot of negatives I think all around when in.
Can I ask Aaron?
More often than not, if we weren't in this current cultural moment, the kids would have outgrown it.
My question for that, Aaron, is like, I'm sure this has happened to some degree. Obviously, like maybe someone who is questioning their gender gets socially affirmed, may like be pushed over that line of not deciding, hey, actually, this isn't for me because of this, like people around them. That's very possible. But my question is like,
Well, just think of how hard it is. Think of how hard it is to walk it back, like especially as a kid, right? Like how hard it is to change your mind, and especially if you made a big stink about something, right? And you were really insistent that everyone like adjust to this new thing, and everyone finally does. It's really, really
Tali,
hard.
I
Sure,
have
but
to
then
wait.
at that
Can I
point, the
push back on
policy.
this? Wait, let me just say one thing, Erda. Because yes, obviously, if you have this very adamant thing that you're pushing for super hard, it might be this sort of like shameful thing to go back on it. But you could say the exact same thing for going into being trans, if not more, because so many people reject that entire concept. It's like this entire society, most of society is like pushing against you, and you're trying to push against that and say, no, actually, I am not what is natural. So like this idea of like, yeah, maybe they would otherwise say they regret it, but are lying, or like they don't want to, like they're doubling down. Like I don't think that's a good explanation for why there's only like a 0.3 to 3% regret rate from the people that do any of this gender affirming care. That just doesn't.
We have just to be clear, we have no information on regret and detransition. So to claim any
No
number
information?
is no, yes, like literally none, extremely low quality.
That's not
The
literally none.
the
That's the best information we have. You can say that it's not good
the
enough, and I
best
would agree it's
information the
understudied, but
best
that's
and
not no
most
information.
up-to-date information we have is from a trans researcher named Kinnan McKinnon, and his research shows something closer to 5 to 15% detransition rates, nowhere close to 0.3%. And again,
That's
he's
not what
pro-trans,
I've
he's a
read.
trans man himself. His interest in detransition is to strengthen trans healthcare. So that is the most up-to-date research that we have, qualitative and quantitative information about detransition. But again, it's going to be lacking because of the decentralized nature of American healthcare system. So this is why I say we have no information. The data set that anyone can pull from is extraordinarily limited. So we should be the number could be 1%, but it could be It's not, I know it's not 50%, but my point is to say anything below 1% is we're just making it up at that point.
Sure. The issue is that, like, if we're talking about if we're talking about interventions and invasive interventions, which, by the way, we do very severe interventions with low to moderate grade quality evidence all the time, like that are standard procedures. People just don't think about them because identity isn't tied to them, right? I think part of the reason why people get so upset about the trans stuff specifically is because identity has prescriptions for how people engage with you, right? And so it becomes this weird thing where if somebody gets a stent in their heart and they're a stable angina, okay, well, there's low to moderate evidence that that's actually effective for non-acute anginas, but also it doesn't affect anyone's life. Nobody gives a fuck. It has no social ramifications whatsoever. What?
Just angina was a funny word. Sorry. Continue.
Yeah,
I know.
sounds like
I was going
vagina.
to say
I
that
was like,
because it's
you're
not
an
sexy.
angina. I'm not an angina. Okay.
Yeah, yeah.
So
Sounds like vagina for all of you 5-year-olds out there.
I just want
Okay,
to clear
yeah,
up for Talia.
vagina.
Real quick, I do want to clear up.
Uh,
Can I just clear up really quickly? That
yeah,
0.3% and then like where that comes from is from that 2023 study from maybe that is that the Jaredajewski? Is that the one you said? And that's not a regret rate. That is 0.3% of people in this group of almost 2,000 people requested a surgery reversal. So there's probably maybe some people that like, hey, I don't want to put in the money, or I'm doubling down on this because now my body is like that would put a little higher than that. I'll concede that, but I don't think, I'm not saying that like it's a 0.3% regret rate, although that is how it decided, but it is an incredibly low amount of people that are like, this is not what I wanted, according to this, not a regret rate.
Right.
But
Of the number of people who are going back to the same doctors even to request these types of revisions or reversals. This is another thing that Lisa Lippman found also in some of her research into detransition, is that a majority of the people that she surveyed did not go back to their healthcare provider to let them know that they had detransitioned or to request additional care, that for various reasons, but the majority of them were not even notifying their healthcare provider.
So this is also
there are
being-
limitations.
Right, and
There are limitations
Surgeries
in what
cannot
we
be
know.
reversed.
Right, not to the same degree that they can be done, right? And so when I am conflating this in the numbers of as well, people self-reported regret as well, right? So that's like kind of unfortunately the best way, which is not great. It's self-reported, but still seems to be incredibly low. So just to clear that up. Not to say like, oh, you're super wrong. I agree. This is understudied. This is not the best quality evidence, and it's very hard to track longitudinally like these people at the same doctors and the same case studies, like even if they like move around. But like to the best of our knowledge, these rates are still incredibly low. And that's the whole idea of why I brought this up, is this idea that, oh, people are afraid to go back on it because they're like, oh, well, and this is, by the way, including all gender affirming care, not just surgeries that are harder to reverse. This is including social transitions, which is why a lot of this data is a little muddied for detransition rates, because this includes non-binary people who, you know, are like, I am questioning my gender, or maybe I could go either way. And then if they go back to what they were born as their birth gender, this is called a desist, which is not really a desist, because just because you're questioning your gender and then decide, hey, I actually pick one of the two things that I was already going to pick. Yeah, what's up?
Hold on. There are a lot of people that I've heard, right, say that non-binary is a form of trans, right? Like I've heard that.
No, exactly.
Right?
That's what I'm saying. It's because those people are identified as trans when they're like, hey, I'm not, like, say you're born male and you're like, hey, I'm not really sure if I want to identify this way or this feels right to me. And then you're like, actually, no, it is. And they haven't really done any surgery or even any hormones. They were just like, maybe I want to express a little differently in public, maybe a little more androgynous. And now I'm going back to doing what society would call more masculine. That's called desisting, which is very different from someone, you know, going through hormones and stopping. Yeah, Erudite.
I just want to be clear. Regret rates, I'm assuming there are going to be reasonably high regret rates for people who end up desisting and had major interventions. That would make total sense to me. I'd be shocked if somebody went through a high level of proceduralism and then decided that they weren't trans anymore and didn't regret it because they fucked up their entire life, right? So I would totally grant regret rates. The issue is that even people who get surgeries that are life-saving, there are multiple, I think the regret rate for cancer surgeries, life-saving cancer surgeries, is anywhere from like 17 to 40%.
Yeah.
Right. So again, I'm not saying that there aren't regret rates, and I'm not saying that those regret rates don't matter. What I'm saying is that we are doing a disservice to trans people by holding the medical practice itself to a standard we are not holding any other practice to. And the reason that I am submitting that we are holding these double standards for trans care versus cancer care versus any other anesthesiology is because fundamentally it's identity based, and we don't like identity stuff because identity has prescriptions and requirements of other people. If I now identify as a man, you are required as a decent person to engage with me in certainly socially scripted different ways, right? And so this is what I'm asking for. I'm asking for a lack of the double standards things to be acknowledged and to be dropped down so that we're being even handed across the board.
So
Let's speak about the regret
Yeah.
situation because it's very, very
Please.
complicated and almost impossible to measure for these reasons. The decentralized nature of this healthcare, as we've already talked about, it's like the person that you go to, the provider that you go to get your hormone prescription is a completely different person than you go to get your top surgery, is a completely different person, provider, clinic, etc. that you go to get your orchiectomy or whatever it is you're having done. These are not centralized clinics. It is not holistic supervised care like it is in Europe. In the US, it's completely just patient driven. And so if somebody has gone on testosterone for 5 years and been like, shit, I hate what I look like now. I don't want to look like a man. I'm going to undo this. They're not going to go back to their endocrinologist and say, undo this testosterone, because it doesn't work that way. It's like you just stop. If you haven't had a hysterectomy, your body just goes back to producing the normal estrogen, and you just live your life as best you can somewhere in the middle. And some of those effects will slowly.
Right, as a
But that's
virilized
probably
female.
fine,
Sure,
right?
but again,
and then like
but
this
again,
being not reported
this
in these stats is probably like irrelevant if these people are doing what is irreversible versus going and getting a surgery, which I agree, if you're going to a different doctor, would affect those stats. But just stopping a hormone, and like you said, if you don't have the hysterectomy, it's going to put you back pretty much to where you were before. Then
It's
this
gonna put
wouldn't
your
really matter.
levels back. It doesn't put you
Right.
back.
Sure, but
Yeah,
Aaron
again,
is saying your body will
we're
go back
doing
to
Hold
producing.
on.
Aaron's saying your
hold
body
on.
will go back
We're
to
doing the double
producing
standards
estrogen or
thing though again.
testosterone.
We're doing the double standards thing again, right? The idea that it's impossible to capture desistance because you're decentralized. It's harder in America, but we capture desistance and dissatisfaction with desistance in multiple areas. It just takes a little bit more like better thinking. And first of all, obviously, I don't want to shift this into a universal healthcare policy because I agree. Yeah, base universal healthcare, fucking better for research, especially. It's way better. I agree with that. But the issue is that you're doing a bit of a weird slip where you're saying, well, because we don't have the same healthcare system, the results of the psychological ramifications of these treatments can't be generalized to American people. And it's like, well, that's not true. Unless there's something phenomenologically different between like American and Canadian trans people, other than universal healthcare. In fact, in the case of in this case, I'm assuming that these are generalizing, especially because the study sample sizes are large enough to apply the generalization. You would need to suggest to me why, in the case in American people, their level of dissatisfaction with desistance would be astronomically higher than an American or vice versa. That's what we need to outline.
Well, I'm not saying that that these are different patient populations. I'm saying that the way that the treatment is provided is completely different, and we can't measure it because it isn't being tracked. There isn't, like, I'm not saying that these are different people at all. I'm saying just the way the healthcare is provided is completely different, and it's not just a case of so when you're talking about a double standard, it's like this is where the trans population is being incredibly underserved and like mistreated, is because there is no actual guidelines for there's no holistic care here. It's entirely, well, it's up to you to figure out where you're going to get this hormone, or it's up to you where you're going to get your top surgery done, and these different providers have their own different requirements, whether or not they are covered under Medicaid or take insurance or whatever. Like, it's just completely haphazard, and there's no oversight, and you don't even have to like really have a diagnosis of this condition in order to seek these interventions. And so when we're talking about regret, and like that 3% who go back to try to get a surgery reverse,
0.3.
basically no one does that. Like you have this surgery, you regret the surgery, but you just go on living your life with your body the way that it is now, because it cannot be undone. Not
Why wouldn't
you're
you get
just gonna
fake
have.
breasts?
What's that?
What would be why wouldn't you get fake breasts? Like say somebody
So
gets a mastectomy, the most common trans surgery, and they end up regretting it. What would be the process by which, like you're saying, they just go on living, they don't report it? Well, I believe that they don't report it to some degree, although lots of people do go back to their primary caregiver or go back to their endocrinologist and report like dissatisfaction. Endocrine specifically, I suspect, would be higher levels of people checking back in about desistance, because they probably want to know the safest ways for them to stop taking T or to start taking things, hormone replacement.
They often
You're
see a
shaking your
different
head.
provider. Well, because they, again, from the information, and we're all agreeing that there's a paucity of information here, but from the information that we do have, they don't go back to the same providers, even if they do. So I agree with Aaron that a lot of people, they just stop. And again, I don't want to turn this into anecdotes because it's not helpful, but like Aaron especially, but we've spoken to a tremendous amount of people who are trans, who have detransitioned, and retransitioned and have been at all different points in this process. The majority just cease, and the ones who do seek care are looking for care from different providers. They don't feel like, and again, this is a lot of the providers, even the ones that they do go back to, tell them there is nothing I can do for you, or I don't know what to do for you, because we have no protocols on detransition. So we have no protocols on trying to reset people or anything of that nature. And why wouldn't people go on to get breast augmentation? Number one, a lot of these people have what they conceptualize as medical trauma. They're not interested in doing any further risky medical interventions, which is understandable. It's also a lot of these mastectomies, they are taking out, I'm not a doctor here, but they are taking out everything. Okay, right? So it's making it a much more complicated reconstruction than to just have like a breast augmentation or something. So it's a much more complicated procedure once you've done a radical bilateral mastectomy.
Yeah,
Gotcha.
the breast
I'm
tissue is
not saying
entirely
that they
removed. The
would.
chest is very tight, and like with trans women, they take estrogen. They produce a lot of excess skin and flesh there that they then can be filled out with fake breasts. But when you've had your existing breast tissue removed, and then then the skin just stitched around, like I've heard of one person trying to reduce or undo it, and she basically had like her chest inflated to a certain degree, and it was very painful
Yeah,
to ultimately get like these little basically breast mounds that look nothing like actual breasts after the fact. And again, for that reason, basically no one seeks to undo a top surgery because, just a lot more pain and heartache for something that's not going to look like your
Well,
original body.
probably most importantly, there's just no research into it, right? And so there probably is actual medical interventions that could be created, that could be offered to individuals, and there could be recommendations of a non-removal of mammary glands and future mastectomies if there's any chance of like potential desistance, right? I'm not opposed to any of these things by any means, right? I'm super open to that. Part of the reason that you're going to have with desisters in having any level of interventionism is because you're now talking about a microgroup of an already microgroup. There's already an issue with getting enough people to study in transgender research, let alone getting enough people to study transgender people who end up regretting and then desist research, right? And I'm not saying that it doesn't matter, that it shouldn't matter. The issue is that the desistance research shouldn't be used as argumentation to take away from trans care necessarily. We really shouldn't be holding these two things together because, again, there are plenty of people who come to regret even things like hip surgeries, but that doesn't mean that we don't make recommendations for hip surgeries. We look at the issues that people have had in the past and we update hip surgeries to try to make them better implementable into people's lives.
So I agree with you. I think, okay, there were a few things there, but I'll just start at the end. So the comparison to other types of interventions like hip surgery, like IBD interventions, like cancer treatments, difference here, the comparison is more apt when we're talking about depression and anxiety and schizophrenia and things like this, but when we're talking about medical complications that we have a strong evidentiary basis for the issue, for the disease, for the problem, that is very different from what we have with gender dysphoria, because it
No, it's
is.
not. No, it's not in this case. When we're talking about low to moderate evidence, we can really do things like comparing stents in like non-acute angines to this.
We can't, because these things are entirely different in kind. They are characteristically entirely different. So we're talking about a cognitive and psychological phenomenon with
Sure.
neural correlates with all these other things, as compared to someone with a broken hip, right? Or cancer that
Of
is
course, of
spreading and
course.
proliferating in
Hold
their
on, just to
body.
pause
So
you.
and
The
so I'm not
analogy,
and
hold
I'm
on.
not
No, no,
saying
hold
that
on,
we
hold
should
on.
get
Stop,
rid.
stop. Just to pause you. I want to back us up. Nowhere at any point is the analogy of a hip to transgenderism, because I think being transgender is like having a deteriorated hip, right? The comparison, the analogy that's being made there is interventionism, the level of
But the
intervention, the
conflation even
invasiveness.
you're saying being trans and having a busted hip. No, it's gender dysphoria, right? It's sex dysphoria and having a busted hip. And what we and the way that we can
Sure, but if
actually
you're being,
determine
well,
and
again,
diagnose these
Tally,
things.
if you're being good faith with me at all, obviously you understand that when I'm saying being trans, I'm talking about gender dysphoric people because
I
I'm not
totally
actually.
do, but here, I
So
totally do. And
then
the only
engage
reason
with
I
me
brought
in
it
the
up,
way
no,
that you
no,
would understand that I'm
Oh
talking,
no!
right? You have
Sure,
to.
sure. But here's the reason that I bring it up. I'm being so
is
good
on
faith.
me.
The reason that I bring it up is because your rebuttal for a lot of what Aaron and I have been saying is that you think the reason that this type of healthcare is being treated differently is because of the identity. That's why I took trans identity out of it and talked about the actual medical diagnosis that we are purporting to treat, which is gender dysphoria. So again, I don't think that you're making some bad faith conflation here, but I don't actually, there are bigots out there. There are people who are uncomfortable with trans people. There are people who are uncomfortable with gender diversity and all of these things with nonconformity. That is not the motivation for a lot of the researchers and clinicians who are raising their concerns. That is not the motivation of a lot of trans people who are raising their concerns. And so I think I think the good faith needs to go both ways. Basically, there are a
Well,
lot of
I
people who are
agree.
sincerely concerned about these things, and it's not because they don't want to touch the trans identity thing.
But Talia, another
Right,
issue
but
here is
again, I just got to go back. I got to hold my frame here. When I'm talking about the identity piece, I'm not saying like I'm not being bad faith and saying you guys just hate trans people, right? That's not what I'm saying. I'm saying that there are double standards of expectations of evidence for trans interventionism that get outlined in things like the CAS study and in this argument here that we do not hold the same standards for other invasive protocols.
Because they
And the
are
reason
different
of course,
conditions.
of course, they are different conditions, but we have to analogize some things at some times and draw levels of comparison, right? And so the reason that I'm submitting as to why we have pediatric care with low to moderate evidence and high levels of interventionalism that people are just okay with and they're not okay with trans stuff is because of that identity piece. And it's not because I think people, like, I don't think you guys are trying to attack trans people and say that they are bad and don't exist. I'm saying the psychological element of the identity piece makes things feel bigger and therefore people don't engage with them in like fair levels. So when we're talking about interventionalism and invasiveness, then we have to compare it to the closest that we have, which would be other invasive things and the level of evidence that we have for these invasive things and if we're holding everyone to similar standards, right? That's what I'm talking
Then
about.
we
Wait,
need
When
to
we
wait,
do
jump
that.
into
Tali,
We need to do
psychological
that.
pieces,
Fine.
we can
Then we
Tali,
need to
talk
do
Can I
about
that
supplement
on
this
both
too? Just one last
axes. Hold
thing.
on.
Can I just
Hold on.
supplement?
Hold
I
on.
just want to
Sorry.
supplement.
We
I
need
don't
to
want
do
to add
it.
another argument. I just
Sure.
want to just like really shortly, like because Erudite speaks longer than I do, and I'm a slow, simple man. So my understanding of this too is that yeah, with something like knee surgery, right? This is something that is like not analogous in the same way to gender dysphoria as we have like empirical, concrete, like here is your fucked up knee, right? Versus like, hey, this is a psychological thing. It's much harder to diagnose. And in these surgeries, we're seeing a higher regret rate, but we're not using this as an argument to take away knee surgery. It's an argument to, hey, maybe we need to improve these surgeries, or maybe we need to do something different here, and not, hey, this is a reason now we should never do this again, or that we should make this even harder for people to get. Just, hey, this could be worse, and even for a more empirically severe condition versus gender dysphoria, where it seems to not have the same regret rates to the same extent. Maybe that's understudied, but that's not an argument to not give the care to the people who are clearly reporting that it makes their lives better.
Sure. And I appreciate that you brought up the difference there because that's what I was trying to say is if we're going to do these comparisons, and I agree we need to be fair, but we need to consider both of the axes here, right? So we need to be fair in comparing it to other low to moderate efficacious interventions, even of the same level of intervention, like you're saying. We also need to compare it to the type. I wish I had better, smarter sounding words here, but the type of diagnosis of issue that we have here, right? So we
the
also need to
validity
look
of
at it.
the construct itself. Yes,
Sure,
like
sure, right. We
deteriorating
need to
hips are
compare
not
it
the same
against
thing.
other cognitive and psychiatric disorders,
I appreciate smart and dumb words. So
not
Well,
just these medical diagnoses that are much clearer to diagnose, if not much clearer to treat. And again, I want to reiterate, I'm not trying to take this care away. I have very severe issues and concerns with the framing of this care because I don't think it's an honest system right now. I think it's got lots of good intentions, but I don't think the system is honest and working in the best is working best for trans people. So I want trans people and people with dysphoria to have access to HRT. I want them to be cautious with surgery, especially with bottom surgeries, because these are very risky. But I want people to have access to all of these things. I don't think the current framework that we have right now is working. And again, I'm not even necessarily asking for higher
when you
levels of
say it's not
gatekeeping. I
working,
think we need
what does that mean?
transparency and we need transparency in what the data actually is. We need transparency in what the process actually is. Right now, we have a system that kind of funnels people into the next intervention, like Aaron is saying, with all of these things very separated and without a holistic, cohesive intervention plan. And also the types of things. Here's the thing too. And again, this is perhaps controversial, but it bears discussing. Even looking into the low to moderate evidence that we have, we need to look at what they're actually measuring, right? And what these constructs are. And so we don't necessarily see improvements in things like career aspects, like interpersonal relationships, like health, overall health functioning, like depression, like anxiety. What we see very often in these studies is a low dissatisfaction rate, um, a decrease in reported gender dysphoria, and an increase in self-reported
Quality of life. Yeah.
satisfaction, basically, and
Okay,
quality of
but
life. And
Tali,
these things, yeah,
you finish your statement, but then I have a question for you, please.
these things are important, but even then, right, we need to tell people exactly what they can expect, and we need to be really looking down at what these constructs are. And so, like we said, there's already, like, just looking at satisfaction is not the most important thing, in a similar way that just looking at people's satisfaction or regret with a knee surgery that might have been medically necessary, even if it's risky and has all of these other negative side effects that people come to regret. Um, I want to take a specific example. So, Wick, I don't know if you want to intervene with your question, but I want to go sort of deep into one of the measures just to kind of highlight what I think these problems are.
Uh, okay, go ahead. But I guess while you do that, have my question in mind. Let me get it out before I
Yeah.
forget it. You keep saying things, and I hear you and Aaron say, like, the system's broken, the system's not working, the system's not doing what it should do. And what I hear from you, and when I ask that, like, what's happening, it seems to be the answer that you give is, well, we're not measuring these things as much as we should be. We're not recording these things as much as we should be. The reporting on this is bad, and that's fair. But I don't know if that means that it's broken necessarily. If, as you say, that most people who go through these treatments, uh, it seems to help them, then why would that not be working? Go ahead.
So again, like, it seems to help them in some ways and not necessarily always. But the problem, I think, what me and Aaron are alluding to, is we don't really know exactly how many people it's helping and to what degree. And because of many of the reasons that people already brought up here, of the concern about this healthcare being weaponized against trans people and being taken away from them, even within the trans community, it's an open secret that people don't talk openly about surgical complications, about complications that they have in transition, because they don't want to take the opportunity away from somebody else. Their mindset is, it didn't work for me, but I don't want to take this away from somebody else. And this works to the detriment of other trans people. And again, there are people who are open about this, and it's for a very
Wait,
good
can
reason.
we pause
My
that right there? Because I agree. I
Yeah.
understand what you're saying when you say, look, there might be someone who would otherwise have not done it because they hear a story from someone who has some sort of medical complication, like with a plasty or something like that. And I'm sure that would cause harm to that person who might have discovered that. But that's not an argument to get rid of the care, because the reason they're not
don't want to
telling
get rid of the
that,
care.
I know,
I
I'm just
can't.
saying,
I
sure, hold on.
Yeah.
I'm not saying you do, but it's like, this is an argument to say that, yeah, we should inform people that there are possible complications if they're going to go through this surgery, which is also what we've been saying since the beginning. Like, yeah, there should be some sort of holistic, multifaceted, multi-step process with psychologists and doctors that say, hey, we're going to make sure you understand completely what is about to happen to you if you want to continue doing this. But to say that this is like harming them on a grander scale than if those people were weaponized, which they are, a lot of detransitioners are weaponized to take away the healthcare completely. I know you're not advocating for that. I would say that's much more of a concern if we see the positive outcomes on a larger degree for most of these people versus the negative ones.
Yes, much more of a concern, and neither of those are good reasons to withhold data or to withhold information from potential clients, from providers, from the general public, from the scientific community. And again, this is what we are actually seeing amongst top researchers in the field, is they are withholding the data because it doesn't show the excessively positive outcomes. It shows neutral to moderately positive outcomes. So I want to hone in again on one specific thing. So I'm assuming I told you guys about this last night, but I'm assuming, at least Kyle, that you already knew about this. But the youth gender affirming care, the model that we use today, the very different model that we use in the United States, originated in the Netherlands. It's referred to as the Dutch protocol, and these were the first researchers to use puberty blockers as a staged intervention for kids with gender dysphoria. And essentially, it was taken to be this great success. It was brought over to the UK. It was then brought over to the United States, and it's proliferated all throughout Europe. And this is the research that started this intervention for children. If you actually go into the research, you see that the number one positive outcome, the highest positive or increase, right? Positive effect, or in this case, it's a decrease, was a decrease in gender dysphoria. Okay. They showed a significant decrease in gender dysphoria and an increase with satisfaction with their body and with their gender. When you go into the methods, the measure that they used, it's like the Ulbrecht gender dysphoria scale or something like that. I forget the exact name. This measure is a sexed measure, right? So you give one measure to males, one measure to females. It's asking you questions like, I get upset when I'm expected to do things that men are supposed to do. Having a penis, makes me distressed. Things that are completely sex specific. They do the intervention of puberty blockers. They go on to cross-sex hormones. Many of these people go on to have additional surgeries. They then give them, in their follow-up study, they give them the Ulbrecht gender dysphoria scale, and they just swap sexes. So now females who don't have penises, many of them don't even have phalloplasty, right? So I'm not trying to shit on and say, oh, your phalloplasty is not a penis, although it's a conversation we could have on a separate day. Most of these people didn't have these bottom surgery interventions, and they were being asked questions about, so there you have a female saying, well, no, my penis doesn't cause me stress. No, being identified as a man in public doesn't cause me distress. No, being referred to as he, him doesn't cause me distress. And so they saw
I mean, I'll just
ginormic.
grant you.
Hold
Sure.
on, let
I
me
can
just let me
grant
just
you
finish
that.
it really quickly.
Well,
So they
sorry, you
saw a
have just been talking
ginormic
for like 5
reduction.
minutes. So if I could just jump in, and pose you a question, just because you've been cooking for a hot minute, right?
True.
Sure. I'll just grant you that the Dutch model, one of the original measures was poor, right? I'll just grant you that as a psychometrist, right? The issue is that I would be extremely dubious that hasn't been replicated since then with higher quality studies, which my understanding of like life satisfaction measures are vastly different now because I've looked at a lot of them and they're much more of what I would expect in any life measure standards. They'll use lots of GAF things, all great measures that I'm happy for them to be using. And despite, sure, the Dutch model being the one that we based it on and the one that maybe has the methodological issue, since then the replications have been done with better quality studies, and we're still consistently seeing we are just seeing a broad amount of evidence, even though you might not like the quality, the broad evidence that we have that is of any level of decent quality is directional to suggest that gender affirming care does improve quality of life, it does reduce distress, and it does reduce dysphoria by and large, although there are cases where this isn't the case and it's not as robust as maybe we would like it to be, which is typically the finding with any care measure, by the way. DMT was fucking everything, and we thought it would cure PTSD until we started doing it all the time. We realized, well, the effect is a little bit more in between, which is to be expected in standard of cares. So the Dutch
And then
model
we
being
walked it back. And then we walk back. It's similar to
no, we
like, and again, I
didn't.
don't. It's
We
such an
didn't hold on. No, you did not walk back DMT treatment at all. DMT treatment is still offered all the time. Ketamine treatment is an extremely
is it a
pervasive
first
thing.
line? It's not a first line treatment for depression.
It was never a first line treatment for anything, and it was never purported to be.
Okay, well, again, so sure, but gender affirming care is the first line treatment for trans healthcare, and we're seeing similar low to moderate levels of evidence for the efficacy of these interventions. It's like
Therapy and
lobotomies.
No,
Again, it's
no, it's not.
Yes, it is. Yes, it is. When you look at the WebPath recommendation, it recommends therapy and social transition long before you go through any medical procedurism. And the puberty blockers
this
has never
doesn't
been
happen.
treated. Stop. The puberty blockers have never been treated as gender affirming care. They've exclusively been used for the wait and watch method to ensure that there is more time for all of the other interventions that are
Can't
non-invasive.
wait to get into that
be
part.
effective or
Yeah.
not effective, right? And so the idea, like, okay, go ahead and respond.
Well, okay, so
You
puberty
both were trying
blockers
to
are
get in. Oh, go ahead. Yeah. I
puberty
just want to
blockers
make
are
sure
just
Aaron gets a chance
absolutely
too.
yeah.
So
Aaron's used to me talking over him all the time.
okay.
Puberty blockers are absolutely part of gender affirming care. So I hear what you're saying. They have different.
I said that they're not part of gender affirming care. I said that they are not specifically gender affirming in their care. They are used
Sure,
in the gender
absolutely.
affirming care spectrum
Right.
as a wait and watch perspective. It is a window to give space for the kiddos to have other non-invasive interventions first.
So okay, so I understand what you're saying. That distinction is absolutely correct. We don't expect dysphoria to go away when someone goes on puberty blockers the same way we might expect it when they go on HRT. So I think that's the point you're making, and I completely agree. We have a few problems with puberty blockers. There's actually, again, I'm against youth intervention full stop, but there's actually evidence to suggest that the safer path for even youth, basically, who are severely sex distressed would be to go straight on to monotherapy HRT and to not do puberty blockers. We have, hold on, let me just get the
That's
thought out.
you're just citing CAS. But the issue is that
I'm
the way
not,
that
no,
the
no,
CAS,
I'm not
yeah,
just, I'm
90%,
really,
98% of people that go on puberty blockers go on to get transition therapy, right? That's the position that we're moving
yes, but
towards.
okay, yeah, hold on. Yes, but that's not the reason I made that claim. So that's another claim that I was going to make. So yeah, so the idea behind puberty blockers was time to wait. There's an excellent book about this by Hannah Barnes. She's a BBC journalist in the UK who wrote about all of this going on in the UK. Basically, her book is called Time to Think, and that is what puberty blockers were set out to do, to give a young person time to think before they make such a huge, potentially life-altering decision, let them figure out what their gender identity is, and give them a pause on puberty before their body starts making its own irreversible changes through puberty, right? That was the desired goal.
Yeah.
What
Can I
they
just grant Tali,
found
real quick,
is
Tali,
that
can I just grant you, like, obviously it's not considered gender affirming care, but if you want to talk about the way that puberty blockers are used in the sense that going through puberty might exacerbate some sort of gender dysphoria, I understand why people call it that, even though that they're like semantically they are different. Like, that's fine. Like,
I consider it gender affirming care. Yeah, I'm not trying to nitpick so much with the terms, but so that was the intent, was to give kids time to care, time to think. We have no evidence that it actually did that, right? If anything, it seems like it plays as the first step in the intervention, right? And so in the UK, where they actually have centralized information and they can measure this stuff, all but one kid who was started on puberty blockers went on to cross-sex hormones and to transition.
but is
And
that the
so
first
that
step, Tali? The
far,
first step was not the first medical step. Might have been puberty blockers, but before that, there are
sure,
therapized
but that's
like
so far
like
beyond
what?
my point.
Well, no, because
Well,
you're
it's
acting
not.
like it's just this thing that you're going right away in, and not, hey, before you do any of this stuff, you've got a team of psychologists and doctors that are making sure that you even should go on this at
This
all,
is
right? Like, I
no, no, no,
That's
no.
not
understand,
how
That's
it
Aaron.
not
works.
You're
true.
well, hold
That's
on,
not
Aaron.
true.
Aaron, you're shaking your
Hold on,
head, but hold on.
especially for puberty blockers, because of the time constraints, especially for puberty blockers, that because of the time constraints, they want to start you on it. And a lot of these kids are not coming in at 10 or stage 2. They're not coming in at 8 and 9 years old. They're
Okay,
coming in at 12,
but
13,
is the
14 years old, and they've already
implication
started puberty.
Talia, is the implication, because maybe this is true, and I don't believe this to be the case, that these kids in the UK, in the system where it's studied well, because Aaron, I saw you shaking your head, and I understand there might be places, because this is not as robust and connected in the United States, where they don't have these checks in certain places. I understand that. But in the UK, is the case
A
that
ton
people
of places,
are
yeah.
going in and like within weeks, they're just like, bam, puberty blockers, no other sort of analysis whatsoever. Like, oh, you said this? Okay, I believe you, here you go. I don't think that's what's happening, but maybe you can tell me that's wrong.
In the
So
U.S., it's within the same day. You show up, you say I'm trans,
Well,
and
again,
puberty
Aaron,
blockers are all they can do.
I understand that might be the
in the
case in certain
UK, you're
places.
asking
I'm
about the
asking about the
UK.
UK specifically for the study that Talia is referencing first.
So in the UK, they ran into a very serious problem of basically they had a shortage of clinicians to deal with this problem, and a huge boom in the number of kids who were coming into their clinics. And so their standards, their protocol was supposed to be a much longer thing, like you're talking about 6 months or whatever of therapy and stuff. And so oftentimes, time wise, that is what was given. So it would be 6 months to a year or something of waiting. But because of the wait list to get into these clinics, and because of how busy their schedules
It'd be
were,
longer, yeah.
these doctors may have only seen them for a total of 1 hour in a full year period before they were given these interventions. And so it might, in a lot of the cases, it satisfied the time requirement, but not the way the time requirement was written into the protocol, right? The protocol was that you're actually having therapeutic intervention, that you're having a thorough assessment, and not because these doctors wanted to hurt anybody, but because they literally didn't have enough people. They didn't have enough time in their day or enough people on their staff to adequately service all these
Okay,
kids.
so even if I'm willing to grant you that this is the case for some of these people, what I'm seeing
You
is,
should read the book.
hold on,
It's excellent.
let me just, like, I'm just trying to axiomatically like follow the train of logic here and tell me if this doesn't make sense to me. So
Sure.
let's say that maybe this is not as strenuous as you would like it, and maybe if that's the case, it's not as strenuous as I would like it. But all of these kids who did go on these puberty blockers, you said only one of them was not then followed through with a higher level of gender affirming care past that. And then also additionally to that, when surveyed these people, to say low regret rates and positive effects on them. So maybe there are some incongruencies and bad things happening here, but like it all seems to lay it out as, hey, these people got what they wanted and they're very happy about it. I'm very confused as to the what is
So if we're
wrong
just
here.
giving people what they want so that they'll be happy, again, I'm okay with that. That's more in line of the true informed consent model that I'm pushing for, but that's not how it's being built. It's being built as life-saving medical interventions based on some recognizable medical diagnosis. So yeah, if the standard is if people want this, they should be able to get it, then we're satisfying that standard. But that's not the standard that these people are purporting to hold themselves to. And so yes, only one person out of all the kids that they saw who went on puberty blockers didn't go on to cross-sex hormones. This already is a huge difference from what they saw in the Dutch protocol and even what they do in the Netherlands today, where they said something like a third of kids that they assess and that go on puberty blockers, they do not put forth to the next step. Another problem is we don't have any type of rigorous assessment. And so it is literally, if the person is insistent enough, that is what we follow. You are literally not allowed in many places in the UK and the United States, you are not allowed to challenge someone's self-report because the identity factor has come in and started to play a large role here. And so
Wait, can you elaborate on
we
that? What do
have
you mean
all
by
of
you
these.
can't challenge? Like you're not allowed to question the whether or not they have gender dysphoria?
Yeah,
when
you could
trying to
literally get in
diagnose
trouble
them?
with your supervisor and be taken off the case. There's lots of reports
Affirmation
of
is
this.
the only option.
Correct.
It's all.
Well,
it's all
hold
they're
on,
allowed to
hold
do.
on. That's not the way that we should be phrasing this. I would agree that you cannot be pushing back because conversion therapy has such a nasty reputation for good reasons, by the way. Which, by the way, if you guys want conversion therapy to be effective, you should be mad at conversion therapy fuckers for being so fucking evil this entire time, right? The reason why their pushback model is so hated is because it was so abusive for so long. And so it's not affirmation. It's almost exclusively exploratory. A therapist would also potentially lose their license if they had a client come in who said, I'm not sure what gender I am, and they go, you're probably trans, right? And so that's not what's happening either. What they're having is exploratory therapy, which, to be clear, is most standard therapy because it's not
No one's
diagnostic.
having exploratory therapy. Almost no one. Kyla, I wish they were.
What do you think I mean when I say exploratory therapy?
Exploring where are these feelings coming from? Talk to me about your life. When did these feelings start? Have you considered other things? Have you experienced any types of traumas? What's your relationship history like? Taking a holistic look at the person, trying to understand where their dysphoria is coming from, how stable it is in their life, how distressing it is to them, and if they're a good fit for treatment. That's what exploratory therapy should be, and there's no version of that happening in the overwhelming majority of clinics. And
I don't see evidence for that. I would grant you. I don't see evidence that
exploratory therapy. Hold on, Kyla.
You
The
gotta let
irony
me
here is
Tally, breathe. You gotta let me talk.
Sure.
What I'm saying is I don't see good evidence for this. Well, I believe that there are absolutely going to be licensed mental health practitioners that are stupid and bad at their job and are just there to yes man their clients. By and large, that's viewed as a very bad thing to do. And most supervisors, even supervisors in very LGBTQ affirming spaces, are not going to necessarily go around and tell you that you are indeed trans. As somebody, again, I have lots of anecdotes of trans people in my community as well who have gone to therapy. And most of their therapy as people exploring their gender identity was exploratory in nature. That, like, I have multiple friends that went for almost 2 years before they decided whether they're going to transition or not. And these individuals, one of them decided not to, and one of them did. But they were given, I helped them find LGBTQ, gender affirming care, gender affirming therapists, and the therapist sat with them and let them figure it out for themselves because therapists aren't rushing to get you transed. They're not. And some are. There are some bad actors because there are always political bad actors. But the issue is that most of them are not doing this. They are doing the exploratory thing, even if they probably have some level of bias of never wanting to say, no, maybe you're not trans. And I would agree they should be allowed to do that too. I agree with you in that regard. But the idea that like everyone is getting people into their clients and just being like, yeah, you must be trans is just not really borne out. And that's not really what therapy looks like ever.
Yeah.
So I have attended multiple conferences for gender affirming therapists and other gender affirming healthcare practitioners, and the therapy you're describing just does not happen. They're not allowed to do it. The only thing that they are allowed to do is this person says I am trans. From that moment, your job as the therapist is to help them facilitate their transition. That is it. There's not any sort of any exploration around this person's experience is framed in terms of their like adverse life experiences due to their transness, due to living in a cis-normative society that is constantly oppressing them and invalidating them. Everything is tailored around cultivating and affirming the trans identity and facilitating the medical process. That is what they are taught their job is. I was at the psychological, what's that? The American Academy.
The APA.
Maybe.
No. Yes, the APA. Yeah. And as they were developing the guidelines for treating gender, I think they're calling gender diverse patients, and that's literally what they were. Everything was affirm, affirm, affirm. I asked, again, my standard question: how do you determine, which person is, like a gender nonconforming cis person and which is a gender nonconforming trans person? And they told me only a transphobe would ask that question. There's no answer to actually doing an assessment. They're not allowed to actually do assessments. It's just, you're trans, great, let's get you transitioned.
And I wanna follow up to the people that you're talking about, Kyla, for example, the anecdotes that I do take seriously. I think it's very likely, especially if they're your friends, that they are thoughtful, curious people, and the exploration that they did was patient-led. They wanted to delve into their psyche and understand why they're feeling these things and if this is going to be the right path for them. But the overwhelming, again, this is just what's happening. So there are obviously people who are bucking this trend. If you go into more conservative or even anti-trans places, yeah, they're a lot less likely to just affirm you. That's absolutely true. I don't deny this at all. There's going to be older psychologists and therapists, like generationally, like boomers, who are just not up to date on this stuff, and they're going to be more likely to explore or whatever. There are a growing number of gender critical therapists who have their own biases against any type of transition, and they're more likely to do explorative therapy. But if you want proof that exploratory therapy, this is not great proof, so this is a little tongue in cheek, but if you want proof that exploratory therapy is not happening regularly in trans affirmative healthcare, go into a trans community and ask them what they think about exploratory therapy. Exploratory therapy is a slur in trans communities. It is a slur synonymous with conversion therapy. I'm not being hyperbolic. I wish I were being hyperbolic, but I'm not.
Just to be clear, I'm not here to defend crazy trans communities. I'll be the first to tell you that trans communities are fucking crazy, right? Lots of people
But
in
the
my
crazy
audience.
trans communities have
Lots of
infiltrated
people-
WPATH and the APA.
Correct.
The
Wait,
issue is that WPATH and the APA have third-party things that they are required to be honoring to, that they can't just do insane shit all the time, or they're going to be liable for it. If it is the case that all
The
all
WPATH
these
does not
things
have
that
any
they-
type of
if I'm just
accreditation
gonna
at
talk over you now,
any level.
Tally, if you keep talking over me all the time. If it is the case that WPATH and the APA are just doing all these things that are definitionally harmful to children, that the desistance rates would be so much higher if we allowed it to be, the reality is that the evidence would be there. We would be finding this at large numbers, because when institutions fail at such a massive degree and such a large scale, you see the effects of it. You can see this when you look at there was multiple studies on workers that didn't have access to safety gear that were getting major cancers and health issues within 2 to 5 years of working there, right? When there are systemic issues at a system level that are failing people, you will see evidence of it. And I'm not saying that trans communities aren't fucking insane. I agree with that. In fact, they don't like my position either, and I'm obviously very pro them. So I'm not going to be here defending them and saying any of this shit. I wouldn't be surprised that APA conferences are saying this shit, because holy fuck, I would never be at a conference as an APA person and say anything but that, because they're fucking cowards. But this doesn't mean that this is what it looks like in the practice. Sure, it is probably the case that the people in my community are going to be selection biased to be more interested in thinking in general, and I'll just grant you that. But if what was happening right now was so bad and was harmful to people in such a significant way, I think that we would see these numbers. I think we would be seeing the effects of this. And that's the thing that I'm not seeing.
Okay. So first of all, this has been a pretty robust debate. It's mostly calm actually, but we got a little spice there at the end. I've got some super chats to go through, and then we're gonna close out and get to closing statements, and everyone can have their final arguments and tell people where to find you. But we're not ending the stream after we end the panel, because apparently Israel has started striking at Iran's nuclear facilities, and we're gonna cover that a little bit. So That
Wowie.
stay tuned for that. Okay, and if you
So
guys
I
want
get your
more,
menorah out.
No,
yeah, channel the dreidel powers and stuff like
look,
that. Okay,
Iran and Israel can hash it out. I don't fucking.
but let's read some of these super chats and discuss them, and we'll get through it. $10 from Greg Yo to say, could the panel explain a bit about how the medical process works? How many doctors are involved? What interventions are recommended and when? What sort of support and counseling is available, etc.? Thank you for the $10. I think we've covered that excessively during this debate.
Well, in that
Thank you.
chatter's defense, it does vary by country, by city, by so like that's why there's not
Like
always
clinic
like a
down the road.
and clinic, right? So it's like it's not always like 2 doctors and 2 therapies, right? Like this is very different for a bunch of very different things, and that's why there's never really like one answer for this. And maybe there should be, or maybe you can kind of get that way, move closer to something, but there isn't a solid one. So
Okay.
Typically, there's multiple standards. I even looked up like the American process. By and large, you can't get hormones same day, especially as teens, right? Typically, you have to go through multiple checks of like approval. They might argue that the checks of approval are insufficient and biased, and I think that's totally fine. But there just are these obstacles to overcome, and I would suspect that the obstacles and the wait times that exist, even in America, that are pretty astronomical alone, are going to probably account for why some of the people who finally get on the puberty blockers are probably already selection biased for the people who are already most likely to want to transition the full way through. Not that I think just delay of care should be the process by which we're vetting out people. I would agree that there should be higher protocol of vetting out people, and I wouldn't be surprised if it isn't where I would like it to be, particularly with teens.
Okay. £5 from Jacob Buckingham, probably the most British name we have. Says this, nice to see a discussion that isn't the typical it's immoral or delusion you get from the Daily Wire types. Thanks to all of you. Well, thank you, James Buckingham. $10 from Alexander Wrin to say, does the social pressure against studies that found negative results from transition exist in other areas of medicine?
I think it's hard to compare those things. I'm sure that they do exist, but like the politicization of transness is not really comparable to a lot of other medical things. I think vaccines would be maybe the closest thing, and again, it's an argument for being anti-intellectual. Like, yeah, you do see sometimes that people won't release data that they might think would hurt a community, but the reason it comes out is because it's not like they just burn all the files. It's like, hey, we're not gonna like go to all the like science journalists, or hey, like we might not make as big of a stink about this, and not oh, like every single study that shows that actually the suicidality isn't going down, the quality of life isn't going down. They just like throw all those away because they're scared of hurting the trans community. I don't believe that's happening. Although there obviously is bias in this to an extent.
$5. Oh, I'm sorry, $10 from Alexander Wren. He gave me another $10. Thank you. How do you expect kids to figure things out if puberty blockers are also slowing or blocking brain development?
Great question.
My understanding of the evidence of like the stopping brain development is a little bit like wishy-washy. I don't actually know to what degree it's actually stopping brain development. And the idea, again, you would have to show that even if there's like brain development being delayed, if there is it specifically in a way that's irreversible? And secondly, is it in a way that would presumably make us believe that they can't make decisions about their gender,
Yeah,
right?
like
You can be
specifically
like,
frontal lobe or something like.
10-year-olds can make decisions on things that 14-year-olds can and can't, right? Like there's things we allow 10-year-olds to approve to because 10-year-olds can understand it. So like the brain development alone, I don't think is like fully sufficient. And again, not sure if there's evidence for what you're saying.
Well, and I think there's truth to the idea that like different people have varying levels of cognitive abilities. And this is a conversation that I have with a young trans friend of mine who is pro youth intervention. And she says all the time, like if a 16-year-old is cognitively able to consent and to understand the risks, that should be good enough. And while I understand that, I think that's somewhat compelling. It's still the fact that they are like too young to make these decisions for the rest of their life, especially if we're talking about things like foregoing fertility and things like this into the future. So my concern is still not just about how smart any one individual young person is, but the long-term implications that time allows you to consider.
Okay. $5 from Audacity to say, yeah, we're exploring therapy, all right. Exploring around till we find the doctor that agreed to give us the treatment we want. Thank you for the $5.
I just want to say, like, the
Well,
way that some of these
that's not a
people are
trans unique issue.
Yeah, I was gonna
Let's
say
be clear.
the way that people are making it sound with the trans stuff, and I don't think this is borne out, is like I don't know if anyone here lived in California back before 2018 when weed was legalized, but you had these like clinics on Venice Beach that were like it's a doctor, and I guess they were medically licensed who would just you go in and you'd be like my back hurts, and they're like cool, here's your weed card. And I don't think this is the way that this is happening with trans people, or at least I haven't seen the evidence of that. Although maybe people do shop around because they really care about getting their gender affirming care, and some people push back more than the ones that they would otherwise want. I don't know.
Okay. $10. And this is from Alexander Rin to Not So Erudite directly. Say, at Not So Erudite, what percentage of the therapists that are going to be highly recommended are going to be doing proper therapy versus pushing them towards exploring transness?
I don't even know if there's like data that we would know the answer to that. And I don't know what you even mean by highly recommended. Highly recommended by APA, then they're probably real decently scrupulous because the APA is recommending them. Highly recommended by like your local trans mom, probably less scrupulous. That would be my suspicion.
Okay. And then finally, $5 from Minerva's Miscellaneous. Exploratory therapy, quote unquote, can often be a Mott and Bailey for let's search for trauma forever and never allow you HRT access, end quote. Thank you for the $5. Okay, with that said, and with that gone through, I'd like to thank everyone for this debate. If you've enjoyed this, hit that like button, hit that subscribe button. We got some great stuff. And again, we're not ending the stream after the conclusion, so don't go away. What we got coming up? So on tomorrow, I have a twofer. Irrelevant versus Admiral Gibbs, and Tali will be joining me. She's going to be co-hosting this. And we're going to be debating riots and the LA riot situation. That should be fun. On Sunday, we have Hutch coming on with Staxiums, and they're going to be
Hey.
fighting against Charlie and her friend, who think that the violence and the looting is perfectly acceptable. And people pushing back against it are just soy boys. Sorry, no offense, soy pill, right?
I have to make a
And
call
so,
after this. I didn't know Charlie was on that side. Yeah.
so yeah, well, she is. But we're gonna talk about it. So tune in, and it's gonna be great. And that's what we got. But I'm gonna give Aaron the first word, soy pill the last word. Aaron, close us out. Tell people where we can find you, and what are your closing thoughts on this? Go ahead, please.
You can find me mostly on X, formerly Twitter, as Allegation Vein. I also have a Substack that I'm not super active on lately, and then also the Naval Gaze podcast that Tali and I do together. Final words is just, I think before we kind of move further in what it is that what should be provided as far as trans affirming healthcare, we should find out what trans even is. And I'd just like to request research into what gender dysphoria is, what it is these doctors are treating, because they don't know. They're just prescribing because that's all they're allowed to do.
Okay, well, thank you again for being here. Really appreciate it. Check them out, gang. Not so erudite, please.
Yeah. Let's trans your kids, guys. My name is Not So Erudite. You can find me everywhere at Not So Erudite. YouTube, Twitch, Kick, all the like, Twitter, and in your mom's bedroom, at least every Thursday.
Damn. Well, thank you for being here, and appreciate you. Go check her out, gang. She's great. Links to all these people are in my YouTube description. Holly, please.
Thank you guys for a great discussion. Kyla, I'm sorry for talking over you so much. It's a bad habit of mine. But hopefully we can talk again. I would love to go even further into this with you if you're interested. I think you're a very competent person to discuss all this stuff with. The reason I was so excited for this conversation, and one of the reasons I think it went really well, is because so much of this conversation is had by the freaks and the bigots and the extremists, right? Kyla, you commented on how a lot of trans activists can be really crazy, and a lot of the anti-trans activists are really crazy. Even the ones who call themselves feminists, even the ones who call themselves pro-gay and stuff like that. People have lost their fucking minds, which is why Aaron and I really don't have friends in the gender critical space much anymore. So I'm desperately trying to reclaim this conversation by moderate, sensible people who care about the well-being of trans people, so that we can get to an end state that is optimal for all people with gender dysphoria. Something we didn't get to talk about much is the fact that a lot of people with gender dysphoria can live happy, satisfied lives without a full transition. There are people who just take HRT but live in their birth sex. There are people who really can sort of accommodate with a social transition minus the change of pronouns and stuff like this. And these are all things that really should be explored if we're looking at the best possible outcomes for dysphoric and trans people.
Okay, thanks for being here, gang. You can check her out on the Navel Gaze and my show,
Oh,
where we
yes.
co-host a show probably every week. So we don't have a name for it. If you want to give a name for it, please suggest good ones because we can't think of one. Last but certainly not least, the man, the myth, the legend, Soy Pill. Go ahead.
Yeah, I'm Soy Pill. I make video essays. You can find me on YouTube, apparently Twitch now, because I co-stream, and Twitter, the only acceptable thing to dead name. I just want to say thank you to everyone here. This was probably the best and last most good faith debate I've ever had, where everyone was very vehemently engaging, acknowledging the points of the other people and clarifying, and no one was mean or rude, and everyone was listening. This is never going to happen again. This is like a miracle lightning in a bottle. It's like the Lord of the Rings film. So I appreciate you guys. And sorry, chat, that I didn't scream at anyone. But yeah, my points really haven't changed from the intro. I still have yet to see the evidence that this is some horrible, harmful thing that is happening. I think it's great that we all agree that there should be good checks to making sure that anything that could otherwise cause harm because it's not reversible does have some sort of exploratory therapy or some sort of like medical assessment, which is hard because it's a medical thing, or it's a thing in your brain. So it's going to be a difficult thing, but I'm glad that at least everyone on this panel agrees that to some degree, these people are happier, and these people should be able to get this care. It should not be barred forever. Maybe it should be harder in certain circumstances. That's cool. I'm very happy. Kyla, I agree. Trans communities are insanely based. I'll say that because they're all so cool. So thank you very much, everyone. Thanks, Rick, for having me.
Okay, thanks for being here, gang. I'm gonna move you all out. Soy Pill just called my panel boring. But thanks for being here anyway, and I'll see you guys when I see you. Bye bye.
Guys,
Thank
thank
you.
Bye.